This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast. Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors. A place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. In this episode, A Surgeon's Perspective, we welcome Dr. Shilajit D. Kundu of Northwestern Medicine in Chicago. Dr. Kundu is Chief of Urologic Oncology in the Department of Urology and an Associate Professor of Urology at Northwestern University's Feinberg School of Medicine. His clinical and research interests are in urologic oncology and published on prospective evaluations of patients with urologic cancers, including prostate, bladder, kidney, and testicular cancer. Let's get to know more about Dr. Kundu. Ellen Shay, take it away.
Thank you very much for that introduction, Dennis, and welcome to Prostate Cancer Real Talk. This is Elle. And I'm here with my wife, Shay. And as Dennis said during our opening, we're very committed to creating an open dialogue, a community of individuals that are going through the diagnosis of prostate cancer. And we're here to discuss some of the issues that you just don't talk about every day. So with that, I'd like to say hello to my wife, Shay, and welcome her to the broadcast.
Hello, Elle. How are you?
I'm doing very well. Thanks to Dr. Kundu. I'd like to welcome Dr. Kundu to our podcast. Hello, Doctor.
Okay. Hello, and thanks for having me. I'm excited to be here to kind of give and disseminate the information and disseminate what information I can so patients and individuals can be more informed.
Shay, I think you wanted to start out with a question that you had for Dr. Kundu.
Oh, I have a lot of questions for Dr. Kundu. But welcome, Dr. Kundu. Thank you so much. As Elle mentioned, you're his personal surgeon, and I'm so grateful and thankful to you for taking amazing care of my husband. So thank you very much.
Yes.
So I want to start because I just didn't know a lot about prostate cancer. And I know you have so many patients, and you probably can't remember when Elle and I was there and you told Elle for sure that he had prostate cancer. My first thing, I was in complete denial. And I said to you, I was like, well, can we just go home and I give him garlic for about 3 months and then we come back and you do another biopsy on him? And you said to me, you're like, no, it's cancer, you said. Yeah. So I want to start because I just knew nothing. So could you please explain to the listeners exactly what is the prostate and what is its functions?
Yeah, that's a really good question. So the prostate is an organ that sits in the pelvis of men, and it sits right below the bladder. And essentially, we don't understand fully what the prostate function is other than giving men problems either earlier or later in life. But we think the main function of the prostate is to actually help with fertilization and for fertility. So without a prostate, the certain fluid can't be made ready for fertilization. But it's in a very sensitive area, and realistically, what happens is as men get older, the prostate grows. It's a natural portion of aging, natural part of aging, and so there can be problems with prostates, such as prostatitis, inflammation. Men, as they get older, almost uniformly get some degree of prostate growth that may not be related to cancer. And that's why men may have some urinary troubles as they get older. In fact, many men do. And then the last that we'll talk about, which is what we're focusing on here, is sometimes the glands or cells within the prostate itself become cancerous. And if they become cancerous, then what we fear is that those cancerous cells can leave the prostate and spread to other areas of the body.
Okay. Now, so Dr. Kundu, his PSA levels were extremely normal forever. And he had a spike like in a very short period of time.
Right.
So I couldn't understand it. And perhaps you can help me and the listeners understand why that may have happened.
I think that's a really great question. And I think what we need to understand is that the PSA stands for prostate specific antigen. So P, prostate specific, S, antigen, A. So all men make PSA, and the PSA really isn't the problem. Rather, it's the cancer that we care about. But as a man ages, generally the PSA goes up. So what we can say about the PSA is that it is specific to the prostate, and all men will have some PSA, but it is not necessarily cancer specific. So just because a man has an elevation in his PSA, does not necessarily mean that he has prostate cancer. But really for us as urologists or people who treat prostate cancer, it tells us, hey, pay attention. Something may be going on here. And so, Shay, as you mentioned, what we expect is a slow change in PSA over time, and that's expected for a man, or really any man above the age of 40 or 50, and more as you get older. But when Al had a little spike up in his PSA, even though that you may have a little bit of growth of the prostate over time, well, a spike up is something that tells us as urologists that we should investigate, and that's what led to the diagnosis.
Okay. So in the office, you said when you explained the process, because we actually elected to do the surgery. So what would you say are some of the determinant factors that a person should consider, whether they do radiology or surgery?
Yeah, that's a really excellent.
I guess radiation. Yeah.
Radiation, right. Well, let me first say, I think it's important to have the discussion. Some doctors and some patients don't want to check a PSA because there is some controversy over whether checking the PSA is actually beneficial. Now, for clinicians like myself who treat prostate cancer, we absolutely do believe in the benefit of PSA screening. However, I think it's important to understand and counsel patients up front that there are some controversies about PSA screening. And the downsides of even checking a PSA is sometimes there can be false results. So men might not have prostate cancer, and it could really lead to worry and procedures and things like that when they may not need it. They may not have prostate cancer at all. And I think it's very important to at least counsel a man or family or whomever is involved in the decision-making process that a test like this, while it's not perfect, is something that we think is worthwhile investigating. And while there is controversies, we do participate in what we consider shared decision-making process. Mm-hmm. And I'll tell you, there are people who are very different. Some men and women will say, of course, I'd want a test. It's a simple test, and I'll be willing to accept maybe a certain level of false positives and things like that, at least to know. But there are other people who wouldn't. So I think the first critical thing in terms of prostate cancer screening or checking is to have and have a conversation with the patient and know that a test is out there. No test is perfect, but it's out there and it can help really save a man's life. Mm-hmm. So once a PSA elevation is found, we don't automatically, historically we used to say, okay, you need a biopsy, but we have a lot of now adjunctive tests that can tell us that we've utilized a lot more in the last few years that can tell us if a man needs a biopsy. Now, these are certain blood tests, certain x-rays like MRIs that can be used to tell whether we should proceed with a biopsy. Now, once we kind of move beyond that, if a man gets a biopsy and he has prostate cancer, then what we want to know a couple of different things. Number one, what is the PSA? Because even though it's not perfect, there is a good correlation between how high the PSA is and kind of the aggressiveness or the risk of the cancer. And number two, what does the cancer itself look like when you do the biopsy? Because not all prostate cancers are created equal. Some are what we consider slow growing and less aggressive. Some are what we consider middle of the road prostate cancer, and that's what L had. And we would generally recommend treatment for those. And some are considered high grade or high risk. And those patients are definitely at a higher risk of the cancer leaving if it's left untreated. So I know it's kind of a roundabout way of doing it. Then we have a discussion of what we want to do. So we used to, if a man had prostate cancer and if it was low grade, we'd say, oh, it's prostate cancer, let's treat it. But we've gotten a lot smarter and we've gotten a lot more adept at really realizing what cancers are really potentially threatening to a man's life. And we really start to say when a man has something called a Gleason 7 or grade group 2 or higher, that's where if we think that that man has a reasonable longevity or life expectancy, then we generally recommend treatment with, as you were saying, either surgery to remove the prostate in its entirety or radiation where radioactive beams are delivered to the prostate without having surgery. Now, the question of who and when or why, I think the bottom line is what I can say is radiation and surgery are very effective. They're equally effective, but each has its distinct advantages. So it really oftentimes will come up to when you're given somebody an option of this is what we want to do, we kind of listen to the patient and we go over the good and the bad, and we let the patient decide. Mm-hmm. It's one of the few cancers and one of the cancers where you have options. Other cancers, you really don't have many options. When I say that, meaning you have an option between getting chemo and then radiation and then surgery, but it's very what we consider algorithmic, meaning you kind of have one path. But with prostate cancer, you could have more than one path. So what we do is we kind of lay out the outlines, options, and we come up with a shared decision-making process with usually the patient or the spouse or the family member, and really anybody who wants to participate.
You know, Dr. Kundu, the decision-making process for me, and I'll just review what the game changer for me and the most distinctive reason why I elected surgery was when you told me that there's no surgical option after you choose radiation. So, you know, when I heard that, I made the decision that, you know, I was going to go with the surgery. And then also the radiation, it was quite frequent. The frequency and the one-way street kind of changed my mind. Could you talk about that a little bit, please?
Yeah, I think the one of the benefits of surgery and radiation are very different. They're both effective, but very different. And one of the main things that oftentimes will happen is radiation, while it's extremely effective, it does cause some scarring within the area of the prostate. In fact, a lot of it. Now, that doesn't always mean a man will feel it, but if the cancer returns after radiation therapy, you can't really get more radiation because it's kind of a one and done type thing. And so doing a surgery, what we call salvage prostatectomy, that means if the radiation works for a handful of years or whatever period of time and it comes back, it is very difficult to do surgery, what we call salvage prostatectomy. And that does limit some options for a patient if a cancer was to return. Mm-hmm. So I think that's one of the biggest benefits of surgery. Is it really, but what the opposite is actually not true. And if a man has surgery, we don't cure every single man with surgery alone. It does take sometimes what we consider multimodal therapy or multiple types of therapies where we ask a man or we really recommend a man gets additional radiation therapy after the prostate has been removed because he either has very high prostate cancer, high risk prostate cancer, or the PSA never achieves what we consider a 0 level. Now, I know, Al, for you, your PSA has thankfully achieved a 0.00 level. As you remember,
I'm into zeros.
You're into zeros, as we all are. We always, as doctors, we're always so happy to get that lab result, and I'll tell you, PSA 0, see you later. Yes. Mm-hmm. Without any additional therapy. And one thing that I said is before a prostate cancer diagnosis, the PSA does have some challenges or problems potentially. But after, specifically with surgery, one of the things I like about surgery specifically, while it's certainly not free and it's what a man has to put up with, is if we can achieve a PSA of 0.00, which is what you were able to achieve, El, is that we can say, hey, we're in good shape. So afterwards, it's an extremely powerful test, and it can tell us whether a man needs any additional therapy or not. And thankfully, many men can achieve your level of 0 and will not need additional therapy.
So as we continue the discussion about what prostate cancer is and whatnot, one of the key points of discussion that we have on our podcast is being an African-American man, myself, and finding out more about the fact that we just have a higher propensity for prostate cancer and also a higher level of fatalities, unfortunately, and what have you. And I know you don't know the answer to this question. If you did, you'd be getting the Nobel Peace Prize or something. But what is your perspective personally and professionally on why is it that African-American men come up with this disease so frequently, and why is it so devastating?
Yeah, I think that's it's a tough question to answer because there is no one answer. I think it is multifactorial, meaning there are multiple reasons. With all of our cultures and our backgrounds, we live differently, we eat differently, we have genetic ancestry that's different. I'm from India, so I have my genes are from certain areas, and men of an African background have a certain there are some genetic components of things that could contribute to a higher risk of prostate cancer. But the reality is that's probably not the only factor. There are other social, environmental, dietary factors that could be certainly contributing. So I do think it's something as relates to ancestry and the genetics of ancestry and how it contributes to a increased risk. But I certainly know that there's a lot of work that's being done now to understand why certain African Americans are more at risk. And if your ancestors are from a certain portion of Africa or certain portions of other areas, is it different based upon ancestry, the genetics of that ancestry? But it's also a combination of dietary factors, environment, what we live, where we live, what we drink, and it's very complicated. And I often have patients ask me, why did I get this? And prostate cancer, it's hard to answer that because we don't exactly know. You know, you guys have probably, one of the biggest things that we can say is, well, lung cancer. Mm-hmm. There are people who get lung cancer who have not smoked, but it's one of those things that if you got lung cancer, there's a high likelihood that you probably smoked at some point in your life, but that's not necessarily true for prostate cancer. So it's a tough question to answer, and I'm not trying to not give you an answer, but it's because we don't exactly know. What we do know is that African-American men are more likely to get prostate cancer and more likely to die of prostate cancer than white men. Mm-hmm. So we do take into account the fact that we need to be careful in screening and treatment and make sure we have a tailored plan according to what we think what is reasonable to do from the cancer perspective and what the patient or man is really wanting to do.
You mentioned screening. One of the key objectives that we have with this podcast is to make people aware of the importance of screening, okay, and to handle some of the misnomers about it. And so on that front, we want to make sure that we're encouraging people to get screened, and also to let people know that it's not what you call an old man's disease. I mean, you don't have to be 65 plus to get prostate cancer. So, you know, what are your thoughts about screening? When should men begin to get screened? And, you know, to make sure that they're just watching out for themselves. The way I did, I got screened frequently. That was what helped me catch this thing so early.
Right, absolutely. With you, your PSA was stable and took a spike up. And so that's a tough question. I think screening is one of the most controversial things that we're dealing with in terms of prostate cancer. It historically used to be all men over the age of 40 would get a PSA, but now we've de-escalated some of those screening recommendations. Some of our larger urology-based societies and the American Cancer Society and things like that recommend screening men usually between the ages of 55 and 70. And that's kind of all men looking to say, look, if you're a man of average risk, and African-American men are higher risk, but the recommendations are a little bit less clear, is generally if you are a man between the ages of 55 and 70 with a 10-year life expectancy, you should consider, not absolutely, have a discussion with your doctor on whether you'd want to participate in screening for prostate cancer. Now, I want to make clear what is the definition of screening. Screening means if you have no symptoms. You're coming in, I'm doing fine, doc. Well, it's doing a test when a man has no symptoms. It's very different than if a man starts to have bad urinary symptoms, bleeding, or something of that nature, because that's not a screening test. That's what we consider a diagnostic test. That's checking for a problem when a man is having. So what we're talking here about is screening. My personal take is I do start earlier. Certainly if you have a family history of prostate cancer, I like to know when a man's either siblings or specifically father, if he had prostate cancer, what age were they diagnosed? And I usually like to start about 10 years prior to that. Mm-hmm. And I at least offer men over the ages of 50, at 50, if there's no family history of prostate cancer, the opportunity for screening, and I have a discussion. And many men are very amenable to it, and some men would like to hold off. Mm-hmm. So I certainly think family history is a big one. If you have a strong family history of either a brother or father, then you should start screening several years prior to when they were diagnosed.
Could you talk a little bit about the symptoms? So if I'm listening to this podcast right now, I'm like, well, how do I know? How would I know if something's happening or not? What are some of the things that the guys should look out for?
Yeah, what's interesting is that oftentimes when we diagnose prostate cancer, a man has no symptoms. Before the widespread use of PSA, really we were diagnosing prostate cancer at a much later stage. So while we didn't find a lot of kind of those low or slow growing cancers, when we did diagnose with men with prostate cancer, it's pretty advanced. So really oftentimes when we screen for prostate cancer right now, a man has no symptoms. And that's the whole point of screening, checking a blood test or an x-ray or doing something when a person has no symptoms. If a man was to have symptoms, that could be a kind of a sudden change of their urinary symptoms, meaning peeing a lot more, getting up at night, some bleeding and things like that. But one of the challenges is, I told you, as I mentioned earlier, that men, as they get older, their prostates grow. They don't have prostate cancer, but they have something called benign prostate hyperplasia, what we call BPH. And 50% of men at the age of 50, 60% at 60, 70 at 70, and so forth, will get some degree of prostate growth. And those men have some urinary troubles, and that doesn't mean they have prostate cancer. But usually if it's bothersome enough, they bring it up to their primary doctor. And I do think there is some overlap in terms of symptoms of prostate cancer. So we do recommend PSA, at least I do recommend PSA check and prostate, a finger exam at the bottom, or what we call the digital rectal exam, to make sure there's no hard spots on the prostate and to make sure prostate cancer isn't causing some of those symptoms. Mm-hmm. In its more advanced stages, people can have bleeding or can't urinate at all, or pain in the bones or other areas if it spreads to organs. But luckily, we can find most prostate cancer much earlier than that if we actively screen for prostate cancer before they have symptoms.
So when we were talking earlier about guys' decision on what to do, surgery versus radiation and whatnot, I had a thought. And my thought was, I think a lot of it with me had to do with the confidence level that I had in the medical facility and also in my surgeon. Okay. And I'm not trying to bribe you because I know you're not going to, there's nothing to win here. So by bribing, so I'm telling the truth. And I don't even know if you know this, Dr. Kundu. You were recommended to me by my general practitioner. You're not the only surgeon there.
Sure.
And so I told him, my question to him was, and I won't mention your name, but I said, if you were going to have this surgery, who would you select? Mm-hmm. He selected you. That was one confidence box that was checked. The other confidence box that was checked was on the facility itself. Northwestern medicine is not just some random hospital. Okay. We're very fortunate to be in the Chicagoland area where there are a number of great hospitals, but I happen to be a Northwestern medicine fan. obviously. And so I think that, if you've got that level of confidence in the facility and you've got that level of confidence in your general practitioner, and, I just listened to the people who I had confidence in. What are your thoughts in terms of advice that people get on selecting, the facility that they go to, if in fact they have a choice? And what are some of the things that people should think about before selecting a surgeon?
There's a lot of great prostate cancer doctors, not necessarily even surgeons, radiation doctors, medical oncologists that treat prostate cancer, both in men who have cancer only in the prostate and for men who have cancer that's spread outside the prostate. I think, frankly, the number one thing is the relationship of trust between the patient and the doctor. We all have our individual styles of how we interact with people, what we are like. And I think I'll say I think I try to do my best, or do as good a job as I can, is trying to be as honest as I can with the patient and say, here's what we can do. It's never okay, or it's never really good practice to say, here's what you need to do. I think that it's really laying out all the information. And oftentimes people would ask me, well, what would I do in my situation? Or like you said, you ask your primary doctor, what would you do, or who would you go with? And that goes a long way. And what you're saying here is you had trust in your primary doctor and you had trust in me. And I, very grateful for that from both your perspective and your doctor's perspective. But, there's so many things. If you ask me a lot of things that are outside of urology, I wouldn't know. If you ask me something about neurosurgery, and to be honest, I don't know a whole lot. So I have to ask people who know more than I do. And that's the way the world works. So I think it's really having confidence in the person with whom you're speaking, with the person with whom you're interacting, knowing that they can take care of you in the way that you need. And in terms of the facility, you want, and this is not just unique to prostate cancer, but for any kind of surgery, the more the facility does, the better it is. Because while it's not routine for you or any man going through it, or any patient going through any kind of procedure, you want it to be routine for the people that are working on you and trying to take care of you. So for us at Northwestern Medicine, no patient is routine, but it is routine. You want to be somewhere where they do it all the time. Mm-hmm. And that's really, I think, one of the critical factors.
Mm-hmm. Okay. So Dr. Kundu, so I want to go to the actual surgery. And one of the questions that I forgot to ask you was, how long is the surgery? And Elle has had a couple surgeries, minor stuff. And I'm just that wife that's a little anxious. And I always want to know, how long should I, anticipate that he's going to be in surgery? I forgot to ask you that question, but Elle's surgery was long. So generally speaking, how long would you say this surgery should last?
It's variable. When we're doing robotic surgery now, a lot of the time is preparation. Mm-hmm. So there's really a good solid 45 minutes of preparation from when Elle left his room till we even got started.
Okay.
Part of that is putting you to bed, putting you to sleep, positioning you, cleaning up. And then what we do is with the laparoscopic or the robotic instrumentation, it takes another solid 15, 20 minutes to really put that in to actually where you're starting the procedure. From that point, it usually takes about 2 to 3 hours, depending upon a man's anatomy. Mm-hmm. So it really probably from start to finish could be about, from when someone leaves the operating room to where they get to recovery room, it could be a solid about 4 hours, but it depends. I always say a little bit is there's some variation in that. It could take 2 hours or it could take 4 hours, and it depends how nice your prostate is to us. So I don't remember the details off the top of my head, but I think Elle's prostate might have been a little bit ornery.
Yes, yes.
That makes perfect sense.
His prostate, that's exactly what you said to me. His prostate was not nice to you guys. So Elle's surgery was 5 hours.
Yeah. So everybody's anatomy is a little bit different.
Yeah.
And sometimes it's just sometimes it's easier and sometimes it's more difficult. But in the end, we don't focus on the time. And the thing about doing surgery is you don't know how long you're taking. You're just trying to take the best care of the patient as you can for the given situation. Mm-hmm. But I understand, absolutely. When you're sitting in the waiting room, it's tough.
Well, we actually were smart. Well, she wasn't in the waiting room. She was in her hotel room.
Well,
hotel across the street. So and that's one of those little tricks that we're telling people, on the show. It's like, if you're going in for prostate surgery, get a hotel near the hospital. I've been meaning to really ask you this. So we talk about robotic surgery. And when people talk about robot, which I still don't understand what is, I know that I had these marks on my abdomen, So, I mean, is it actually a robot? I mean, do you actually insert a device into the person's body?
It is a device, but it's not a robot that acts on its own. So what it is, you put these instruments. You guys have maybe all heard of laparoscopic procedures. Those are those are what those little marks are. You put these little instruments into a person's body, and you fill up the belly cavity with carbon dioxide, and that gives you room. And then we're actually sitting a few feet away from you, looking into a kind of a console, kind of like a windshield, I guess. And then whatever my hands are doing, the robotic instrumentation actually mirrors my hands. So if I turn my wrist this way, the instrumentation will move this way. If I do this with my wrist, the instrumentation will do that. And that allows for really more. And the other thing is, with the robotic instrumentation, you have a camera that's looking very close to the anatomy. So you do get some advantages over doing the procedure in open fashion, at least in my hands and in most surgeons' hands now. There are some surgeons who are excellent at open surgery, but kind of the field has moved that way. So the answer to your question is yes, there is a robot that's inserted into your body, but it doesn't work on its own. It does what the surgeon tells it to do.
That's amazing. We've had a couple guests who are from like the early 2000s, in the late 1990s. And one of the guys he's a writer, and he's actually a cartoon writer. Okay. And so the perspective that we had was more or less somewhat of a comical look. Okay, and the name of that episode was It's Okay to Laugh. Yeah. And one of the crazy things that he said was, they cut me open like a salmon or something, it's just started digging around until they figured out what to do, which we know was a little bit better than that. We tried to take somewhat of a lighthearted look at this. So when we're talking to gentlemen and their families about this surgery, another couple we had on, we called them the long haulers. They had theirs over 20 years ago. And so the message here that we have is, when your doctor tells you that you've got an elevated PSA level, when your biopsy comes back and it is positive for cancer, your life is not over, okay? I mean, there's just a lot of things that can be done. And I'd like for you to talk about the longevity perspective, because we've met a lot of people, and I know everybody's not like this, but we've met a lot of people that have really almost flourished, afterwards. Even their relationships became closer. Can you talk about that a little bit?
Yeah, I think that's, we see that a lot, because oftentimes any patient who's diagnosed with cancer, you're doing fine one day, and the next day your doctor, surgeon, whomever did the biopsy tells you, I'm sorry, you have a diagnosis of cancer. And it usually comes out of the blue. That doesn't always happen if it's late stage, but you were fine one day, you had a blood test, and you weren't fine the next day. But it does, if we have an opportunity to have a frank discussion with somebody, and frankly, if you can offer them a chance of cure, and sometimes not even, you don't cure everyone. Oftentimes people get a new lease on life and understand, what are the things that are important to me? What are the things that are important to my family, and how can I cope with some of the quality of life issues that can happen after any kind of, frankly, any procedure, and what's important to me. So I think what it does, at least this is my opinion, is it puts people's surroundings and lives in perspective, and oftentimes will allow them to understand what's important. So as you said, oftentimes it's problems or tragedy that bring people close together. And a prostate cancer diagnosis is not a tragedy. It's just something that you need to deal with. And having a really good support network around you really oftentimes will help bring somebody closer together, because that person may put things or many aspects of their life into perspective and understand what's important for them.
Dr. Kundu, so I knew nothing, when Elle first got diagnosed. I just knew nothing about prostate cancer. And I just left. I was like in a state of shock when I left your office. And one of the things you said when you were explaining the process, because we did, come and we basically told you, yeah, we're going to go the surgery route. Yeah. And so you explained what to expect. And the thing you said was, it was just very matter of fact. And it was like quick and you just kept talking. But you said there will be leakage and you will have to wear the pins. And we looked at each other. You probably can't remember it. We said, depends. Like, we couldn't believe it. I was like, leakage? What do you mean leakage? And you said, oh, yeah, there's going to be some level of leakage. And, he's going to have to wear the pins. So does every guy have to wear the pins? I mean, does everyone have leakage, basically?
Well, the short answer is not everybody, but most men do. And some men have more than others, and about 5% of men have leakage that they're not happy with, that we can help them in long term. Because the prostate does another thing other than cause problems and the fertility issues. It helps to control the urine. Mm-hmm. And I don't remember how large your prostate was, but it might have been quite large. And so men have a prostate, and underneath that they have a muscle. Okay. Women only have a muscle. So when a man's prostate is there for his whole life, really, it's been helping to control and block the urine. But when that prostate is removed, the muscle is all that's left. So a man has leakage until he can regain that control. And oftentimes a man will have to do things, what we call Kegels or squeezing. And sometimes men need help with what we call pelvic floor therapy, because it's hard for some men and women or anybody to really understand and isolate that muscle. We give it time. But there are additional things that can be done for leakage and erectile function and things like that can happen in some men, but almost every man will leak. The duration and the severity does vary.
That's what we want to tell people, because I know there's like people that just not going to know what to expect. So most men will have some amount of leakage.
Yes. And I think that one of the things that I'd really try to say, look, there's 3 things we're trying to accomplish. Mainly, there's other things, of course. We want to control your cancer or cure you of your cancer to the best of our ability. We want your urine control back, and we want your erectile function back in that particular order. Mm-hmm. So oftentimes what happens is people will be like, cancer, I just want it out. And they kind of sometimes will tune out the other things. Yes. And even though we have a discussion, they're so focused on the cancer. Yes. But then eventually you get to 6 months, 9 months, 12 months. And of course, the other things become extremely important. And we understand that. Mm-hmm. And so I'm sure we've had the discussion, but you're so focused
Yes.
Oh my God, I have cancer. Yes, we'll deal with the other stuff. Yep. But as you're saying, now Elle's achieved really an excellent or perfect cancer result, and I hope will continue forever. There are other issues that we need to help him and every man with if he has it. And just because there are problems doesn't mean that there's no hope. It means there's absolutely things that can be done if a man has more leakage than he wants or is happy with, or having erectile function that he and wants better results. But we start off slow, we start off simple, and then we escalate. So we can help every single man, but what will happen is we're first focused on cancer control or cure, and then working on quality of life issues. So every man will have it. And I say, look, you're going to be quite surprised because you're not used to it. Mm-hmm. And so I was like, okay, I got it. And then all of a sudden it happens and you're like, whoa, this is real. Yeah, it is common.
One of the things that I do remember, and you do this so often and you say things, I'm sure, but as a patient, there's certain things that you have said to me that I just really clung to, okay? And one of the things that you said, and I don't know if we were talking about the erectile dysfunction or if we're talking about the leakage or whatever, but you said this and I clung to it. Mm-hmm. And you said, oh, we can always do more. Okay. You said, we can always do more. And so regardless of what happened to me or how I felt throughout the process, I always clung to your statement, okay, that we can always do more.
Of course.
And it was really encouraging to hear that.
Good. Yeah. And I think, our job is not to scare you because you're trying to deal with a very significant problem. So if you give my personal take on it, you want to leave the information out there. And be honest and truthful, but you don't want to scare somebody.
Right.
Because you're already scared. I would be too. So you want to give, you don't want to put so much fear into somebody that they're not able to then make a good decision or a good decision for themselves on how to proceed. So I think it's laying out the information, not trying to scare somebody, laying out realistic expectations, and understand that we have many tools beyond what your body was born with. You're wired, and all men who have prostate surgery are wired a little bit differently now, but they can have a good, normal life expectancy, really cancer-free, at least prostate cancer-free.
Go ahead, Shay.
So, Dr. Kundu, so women have, as you know, hormones, men testosterone. So when you remove the prostate, does it sort of send a man into something similar to like what women would go through in terms of menopause? Okay, because I noticed that L, sometimes he's hot, sometimes he's cold. So
my wife keeps it 80 in the house, so that might have something to do with it.
So I'm wondering if removing his prostate kind of mimics like maybe a lady going through menopause or something.
I think that one of the things about surgery is that actually we don't do the testosterone comes from a man's testicles. So we actually don't do anything with the testicles. The thing that we do is we sever the connection between the vas, when one gets a vasectomy, for example, and the actual prostate in and of itself. So the testicles are actually completely intact. They're a totally separate portion of the body. And so there are treatments usually that are limited towards men with more advanced cancer or with radiation, that they get anti-hormone shots, which actually is a version of male menopause, because you take away a man's testosterone, just like in a woman going through menopause. But oftentimes with surgery, we don't use that, because really there's no proven benefit to using those anti-hormone treatments with surgery, and most of the time.
And so for the guys, because we're trying to give men and families as much information as possible. So getting back to the sexual issue. So what are some of the things that you can recommend or men can do or talk to their doctors about, like once they have the surgery and if they're experiencing ED? So what are some of the solutions for that?
So the first thing we do is give all men, we give men Cialis, daily Cialis, which is kind of help try to stimulate blood flow. It doesn't always work. And I'd say the biggest challenge that I face, or most prostate cancer surgeons face, is erectile dysfunction. So what we can do is we oftentimes start with Cialis. And again, usually what happens is a man is just worried about their catheter and their leakage and their cancer. And then as time progresses, we do start to do more, adventurous things, And one of those things is stimulating blood flow to the erection tissue. And we can stimulate that artificially. And that's not just limited to men with prostate cancer. Men as they age, some men have erectile dysfunction. We can stimulate that blood flow through things like injections. It's injecting a small amount of medicine that will stimulate blood flow and create an erection. It's called intracavernosal injection. It's extremely effective. It sounds scarier than it is. It's not quite as spontaneous, but men can have excellent results. And then depending upon their effectiveness, whether things return or don't return, or their happiness with the actual injections themselves. And there are other options like a vacuum device or something called the Muse. It's like a little pellet that's implanted or placed there to create blood flow. But I find that the injections offer an excellent opportunity to have good results. And then if really things aren't going well, or if a man's not happy, we can do something called a implantable or inflatable penile prosthesis, which is kind of has very high effectiveness, but it isn't a procedure that's put something in there permanently. But very, very high satisfaction with it. But it's kind of one of those things that you save as a last resort if other things aren't. If a man or couple is not happy with where they're at. But that, like I say, there's always something to be done that could be done more, that could be more effective or make life better. But we don't start with that. We start with the simple stuff, the stuff that's reversible, the stuff you can say, not so interested in this. And then we escalate it to more permanent solutions.
So, Dr. Kundu, as we wrap and come to the conclusion of our discussion, I'm quite sure that many of our listeners want to know more. So if they want to know more, and if they consider Northwestern medicine as an option, how can they get in touch with you, or how can they go through Northwestern medicine to find out more about options and treatments that are available to them?
Of course. I mean, we have a very robust, very talented team at Northwestern Medicine. The first thing is I would honestly go and you can always call our office. It's 312-695-8146. We have a lot of excellent prostate cancer surgeons. You can also go on the NM website and put in prostate cancer and you'll find us immediately. In urology, we're a very high volume prostate cancer center because we treat the most men with prostate cancer in I believe the state of Illinois. So going onto the Northwestern website and looking into urology and prostate cancer, you'll find us because we're a very high volume center. We treat a lot of patients and we have a big base. Okay. So we're happy to speak with anybody. We have a big group of prostate cancer surgeons and oncologists that are experts in prostate cancer treatment. So we're happy to talk to anybody anytime.
Before I forget, I want to give a shout out, to Ling, who is Dr. Kundu's assistant. What's her formal?
So Ling is my physician assistant, and she's my right and left-hand person, I guess. Okay. She kind of helps take care of things when I'm off doing other things. So she kind of keeps everything held. She's the glue that holds us all together. So she's been awesome, and she's really, I'm very lucky to have her.
And also to me as a patient, Northwestern Medicine has a great communications vehicle called MyChart. And I know a lot of times people complain because they can't get in touch with their doctors and whatnot. I have not experienced that with anything at Northwestern. I go on MyChart. Shay knows I'm a MyChart user. And if I have a question about anything or whatever, Ling is right back to me in the next day. So I want to shout out to her for her incredible support.
Oh, well, thank you for mentioning it. She'll be so happy you mentioned it.
Dr. Kundu, finally, so do you have any sort of words of encouragement? Like if there's a listener and they're trying to make a decision, do you think they should go in? Men tend to maybe want to go by themselves. Do you recommend that they go in with their family, with their spouse, their significant other? I know that helped us, being there and listening to you together.
I think it's so critical that a person comes with somebody who's going to help them with the decision-making process. The process of any of our medical health, whether that's cancer or heart disease or anything, is scary. And to have someone around you to help support you, to be another set of ears towards things that were said, is so critical. Because we may spit 150 things out at you and you might retain 10, but there are other things that are really, really important. So I really encourage patients, especially once you have a diagnosis, and a lot of people are a little bit hesitant to share the diagnosis for many different reasons. But once you have that diagnosis of any particular problem, bring someone with you who's going to help you make that decision, and you can talk it through with them. Because it's so critical. We want good results. We want happy patients. We want good results in everything we do. And it's so important that the family members or spouse or children or parents or whatnot are involved in that decision-making process. And I think that leads to happier people, happier patients, and that's what we want.
I can't thank you enough, Dr. Kundu. Thank you so much for taking amazing care of my husband. Again, it was a long surgery, 5 hours long. You were awesome. You rocked. And when you made the call, when you called me, you were so kind and you have amazing bedside manner. And I felt like I was talking to, a brother or first cousin or something that just happened to be a doctor. So thank you so much for taking care of my husband.
So delighted to do it. And I look forward to seeing both of you in the clinic soon.
Okay. Thank you. Thank you.
Thank you very much, Dr. Kundu. Thank you for everything that you've done.
Bye, Dennis. Bye, Elle. Bye, Shay.
Bye. Thank you.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@northwestern.edu. at prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, at prostatecancerrealtalk.com.